discuss public health policy in regard to the extensive discourse on the legislation of the Affordable Care Act. We look forward to discussing the current state of healthcare and the possibilities of reform. We are honored to have here today Dr. Bottles to deliver the keynote address. Dr. Bottles is a senior fellow at Thomas Jefferson University School of Population Health. He studies the policies and forces that shape the health of individuals across the nation. To begin the symposium, Dr. Bottles will discuss the 4 things that most affect American medicine and their significance towards the population. We are grateful to have Dr. Bottles speak today and excited at the opportunity to learn from his knowledge. So without further ado, please give a warm welcome to Dr. Bottles.
Well, it's a pleasure to be here, and you couldn't have picked better timing with the election and with Fiscal Cliff, which we're going to talk about, or Tax-Mageddon, which will happen December 31st, January 1st, when the Bush tax cuts and a lot of other things come together and either get resolved or crash the American economy. So it's perfect timing, and I'd like to do this as interactive as possible. I kind of walked around and talked to some of you before, but there's 4 things that I think are the most important trends that are going to affect anybody who's in healthcare, whether it's dental school, nursing school, allied health schools, or medical school. And some of them maybe are not ones that you'd think of immediately. The federal budget deficit's probably the most important one. Then, of course, the Obamacare Act or the Affordable Care Act, the ACA. Demographics. I was remarking to some of the faculty over here how young you all look and how old we look, and yet most of us are going to be retiring, and our Social Security and our Medicare is going to be paid for by you. And there aren't as many of you as there are of us, at least right now. So that's a big challenge for you and for us, and will be interesting. Then technology. We're in the middle of a digital revolution. We're in the middle of patients changing the way they interact with the healthcare system. So we have tons of slides, and if you want to jot down my email address, which is on the first slide, I'd be happy to send them to anybody. We won't get through all of them, but they're there in case we have a discussion about and need some backup in terms of data. So I'd like to talk about those 4 things, and the first one's the federal budget deficit. And certainly you heard about this during the election, but one of the things I said in DC yesterday when I was talking about a similar talk to a World Healthcare Congress was I didn't think it really mattered that much who won the election in terms of healthcare, which may be a surprising thing to say. But the reason I say that is the federal budget is under such intense stress that the only thing that Obama and Romney seemed to agree about was that we have to either cut $4 trillion out of the federal budget or raise taxes $4 trillion or a combination thereof. And that's because we're spending way too much money than we have. And they kind of agreed on that. What they don't agree on, and what you're now seeing the tension between Obama and Boehner, is how do we do that? How do we get that $4 trillion out of the budget? The Democrats would like to do it mostly by raising taxes. The Republicans are saying you can't raise taxes, we have to do it by cutting spending. But if you actually look at this, and there's an interesting book that just came out from the Wall Street Journal. I mean, this is the federal budget. 21% on defense, 21% on Social Security, about 20% on Medicare, Medicaid, and the CHIP programs, and then about 9–10% on the debt. There's some problems. I just want to give you 2 facts, which mean that both the Democratic approach and the Republican approach are flawed. And the 2 facts are the following. In the defense budget, 21%, which is the most, we spend more on defense than the next 17 countries combined. So we spend more money on defense than Israel, the UK, Russia, China, the next 17 countries combined. So to say that you can never cut a penny out of defense is really kind of foolish. Because if we spend that much money, who are we going to fight with another aircraft carrier? It's a problem. So whether you're a liberal or a conservative, if you really look into the facts, we spend a lot of money on defense and there's a lot of waste in defense. Now, having said that, we spend a lot of money on healthcare and there's a lot of waste in healthcare as well. So you're not going to, if you're a Democrat, you're not going to be able to totally protect Social Security and Medicare and Medicaid. And if you're a Republican, you're not going to be able to totally defend the Defense Department budget. So fact one is we spend more on defense than the next 17 countries combined, which I found a little surprising. Fact two is, if you want to be a Republican and cut it by, good morning. How are you? Welcome. Since you're late, you have to ask a question later on. Okay. So the other fact is, if you say, okay, we spend too much money, and the only reason why we have a problem with the federal budget is those fat bureaucrats that work for the federal government. If we fired everyone who gets a federal check, Obama, Biden, every member of Congress, every park ranger, every soldier, every Navy person, fired them all, what do you think it would do to our budget deficit? Anybody? The woman that just came in late. What do you think? What's your name?
Grace.
Hi, Grace. So we fire everybody. We're talking about the federal budget. We're going to fire everybody. How would that affect our deficit? So the Republicans are saying, let's just cut spending to get the $4 trillion out. The question is, what percent of our deficit, if we fired everybody who gets a federal paycheck, what percent would that be? Take a guess, between 1 and 100. It's actually 50%. So if we fired everybody and had no federal spending at all on people, we'd still have a huge federal budget deficit. Those two facts say to me, you can't do this by just cutting spending. You can't do it by just protecting the military. Just an interesting thing. That's about as partisan as I'm going to get today. But the other thing that most people agree on is that the major reason we have this big federal budget deficit is healthcare. Healthcare is the number one reason that our federal budget is out of whack. So we can get into a lot of really numbers, but right now our federal debt's about 62% of GDP, gross domestic product. After World War II, when we borrowed all that money to beat the Nazis and the Japanese, over 120%. When you have a lot of growth in the 70s, it's only about 35%. So we spend too much money. Is there anybody who wants to argue that the federal government spends way too much money and that we owe too much money to China? Because if anybody wants to argue that, it'll take a while to get to the rest of this. Okay, so I think everybody agrees about that. And again, Obama and Romney both agree about that. So basically, a lot of really smart people on both the left and the right. George Shultz was a Treasury Secretary who's a pretty right-winger at the Hoover Institute. Christina Romer is a famous economist on the left. They all agree that we've got to reduce the reduction package to stabilize the debt as a share of the economy. About $4 trillion is the number, okay, that we've got to cut. It's a big number, $4 trillion. So we'll get to healthcare in just a second. Simpson-Bowles was a commission that Obama appointed with one Republican, former Senator Simpson, one Democrat, Erskine Bowles, and they came up with a way, like I just said, you're going to have to cut some spending and raise some taxes to make this work. They took $100 billion and increased tax revenues. They did $200 billion in reducing spending, even in defense. They talked about reduction in entitlements, controlling health care costs. They talked about Social Security modifications, maybe raising the retirement age before I can retire. Okay? So what happened to it? Well, there were an equal number of Democrats and Republicans on it. It went back to Congress. They voted against it. Nobody liked it. Why? Because one person's waste is another person's income. I mean, it's a big, big problem. Okay? So that's something that is now still out there as a framework. And then there's the Budget Control Act of 2011, which is kind of like what we're talking about now with the Fiscal Cliff. In 2011, we had to raise the debt ceiling. We raise it all the time to pay for stuff that we've already decided to pay for. The Congress has already said we're going to spend money on this aircraft carrier, we're going to spend money on this aid to China, we're going to do all these things. The congressional Tea Party folks said we shouldn't raise it ever again. So there was a kind of a game of chicken, I don't know if you remember that, between the White House and between the Congress. And basically what happened was we downgraded the US government debt from AAA rating to AA plus rating. The problem with that is it means that every time we borrow money now, it costs us more money. So basically they were saying the American government debt rating is not as good as it should be because the government can't get its act together and do what it's supposed to do. What they decided was that yes, we'll do it, but we'll create another bipartisan committee, and those guys will figure out a way to cut stuff surgically, make sense. And when they do that, then we'll raise the debt ceiling. Now guess what happened? the government committee got together and it couldn't agree on cuts because the Republicans argued this way, the Democrats argued that way. And so what now is triggered, it's already passed into law, if nothing happens on December 31st, 2012, that's coming up, we suddenly have huge cuts that are automatic in both defense and in healthcare, and everyone's screaming, it's terrible. And it is terrible, because if we do that, it'll ruin the economy, more people will lose their jobs, and we won't get out of the recession. So that's interesting. And some people call it Taxamageddon. What you've been hearing mostly now is the fiscal cliff. Those are the same things. That basically a bunch of things are happening, the Bush tax cuts are expiring, a bunch of stuff in the stimulus bill is expiring, and we have this big problem. So basically, and that's what the payroll tax holiday is expiring and 67 other things. And that's why Obama, again, why it's great timing for today's talk, is Obama yesterday came on the TV and said, I won the election, we're going to raise taxes on anybody that makes more than $250,000 a year, and that's what we're going to do. And Boehner, who's now head of the Speaker of the House, said, no, you're not. So we're still at that game of chicken, and that's what we're going to see what happens next. Now, why am I talking about the federal budget deficit in a health policy kind of talk? Well, the reason is that the one thing that people do agree on is that health care, we spend way too much money, and that's the biggest reason why our federal budget is out of whack. And we just saw that we spend about as much money on health care as we do on defense. It's a big, big number. So as part of these automatic cuts, because the Congress couldn't get their act together, the White House was required a couple weeks ago to say, well, what does that mean for the health care budget, that 20% that's health care? It means that Medicare is going to get cut $5 billion. It means hospitals are going to get cut $5.8 billion. It says that Part D is going to get cut $591. CDC, which takes care of flu outbreaks and all those kind of things, $400 million. Substance abuse and mental health services, $200 million. The FDA, we don't have any problems with food being poisoned, do we? We don't have any problems with drugs that's okay, get rid of that, right? Okay, piece of cake. That's about $300 million. The NIH, new discoveries, we don't need that, that's $2.5 billion. Indian Health Services, $300 million. These are the automatic cuts that are in law right now that are going to go into place, unless Boehner and Obama and Mitch McConnell can come up with some kind of agreement. So this is, basically this is catastrophic to health care. And if we were talking about defense, I could show you the same kind of things that would be just as catastrophic to defense. Big, big cuts. Okay? So that's because we have a dysfunctional Congress, and they don't know what they're doing. Now, what's health care's role? I kept saying, we agree that health care is the main reason why we have this big problem. Health care's role is the following. You have rising health care premiums. If anybody here has your parents have a business, they provide health care to their employees, and it goes up every year. It's very expensive. That means the employers don't have money, which means they can't give raises to their employees, which means that consumers have to borrow trillions of dollars to continue to have an SUV, which means that we then run out of money, default on our mortgages, and we get a recession. That's what we're just coming out of right now. So health care spending is a big, big part of the problem. And remember, 70% of the US economy is consumer spending. If people aren't buying cars, it ruins our economy, okay? So that's where we are right now. Why is it that we spend so much money? Why does health care cost so much? Well, here's the good reasons. Anybody here know what fee-for-service payments is? Fee-for-service, what does that mean? Anybody? Grace, what does it mean? Okay, she doesn't know. Okay, fee-for-service is the way that when you go see a doctor, every time you go see a doctor, there's a bill. Every time you get an x-ray, there's another bill. So basically, it's the way that we pay for health care. And that kind of incentivizes hospitals and doctors to do too much. People say there's about 30%, 40% is too much. Demographics, we're getting older, sicker, and fatter. That's a problem. Pogo's up there because we've met the enemy, he is us. We as patients are always demanding, we want antibiotics for that viral infection, even though it won't work. We're worried about our daughter, we want that MRI, even though there's no reason to get the MRI. So the consumer demand for more health care is a problem. Tax breaks on health insurance. When employers give health care insurance to their employees, they don't pay taxes on that. That's a big break. Lack of information. People can't shop for health care the way they shop for tires or the way they shop for a car. You can find out what's the best thing, especially online, and get the best deal. Healthcare, when you need it, you need it. You don't really shop around. You know, does Lankenau Hospital have a special on MRIs, or maybe Penn's got a better deal this week, or there's a coupon in the Inquirer for Jefferson. I mean, when you need to go get an MRI, you don't do it that way. That's a big problem for driving up costs. Hospitals are and doctors are gaining market share, demanding higher prices, supply and demand problems, and legal issues. There's antitrust problems. You can't just come together in healthcare the way you can in some other industries to cut costs. So for a bunch of reasons, healthcare costs a lot of money. And how much money does it cost? It costs a lot of money, $2.5 trillion, and that's actually up a little bit from that. Without controlling this, the federal budget deficit grows. We spend 2.5 times per person more than people in Europe, and yet there's waste in it. So how many people here think that we have the best healthcare system in the world by any measure? How many people? Okay. How many people here think we have not the best healthcare system in the world by any measure? Well, you know, one of the problems is we spend more than anybody else on healthcare, and the last time the Commonwealth Foundation did the metrics, infant mortality, how long do people live, access to healthcare, we came in 37th, right behind Portugal. So we spend more money. Now, it's absolutely true if you're rich, if you have really good insurance, and you can say the best neurosurgery maybe is at Jefferson, they've been building that up, the best oncology maybe at Penn, you can get really great healthcare in the United States. But by any measure of a whole society, we don't come in number one, we come in 37th. And so we could argue about that, but that's pretty well documented. So we spend a lot of money, but we don't get enough money for our thing. And I just want to, Zeke Emanuel just is over at Penn now, but he used to be at the White House. $1 trillion's a really, really big number. It's not like $1 billion is big. $1 trillion's even bigger. And this slide I stole from him was 1 million seconds ago is 2 weeks ago. 1 billion seconds ago is 1974. 1 trillion seconds ago is 30,000 BC. So $2.5 trillion is more than just a couple billion. It's a big, big number. It's hard to even imagine how big a number it is. And there's lots of charts and all these things about it's going up. But I said, well, how can we make this really mean more to you? I'm going to Costco after this, because Costco is where we get our fruit and where we get our eggs and stuff. Because Costco is cheap, and Costco is wonderful, and Costco, I guess I do have a bias. Costco is the American cathedral. You should all join Costco and get your food there because it's wonderful. Anyway, what are we trying to say? If consumer prices grew as fast as healthcare, okay, since 1945, a dozen eggs would cost $55. I can tell you I can get 2 dozen eggs. In fact, I'm going to today. It's about $3.50 at Costco. $3, not $55. A dozen oranges would cost about $134 if healthcare costs rose at the same rate as consumer prices. And a gallon of milk would cost $48. Okay, if you go to Wawa with a coupon, you can usually get it for about $3.25. Okay, so does that make a point? Healthcare costs have just skyrocketed compared to other things. Okay? So that's a big deal. That's a big problem. So the other thing is, you think, well, healthcare costs, well, that's important. It's important for the rest of society because money we spend on healthcare is money we don't have for the rest of the things we might want. National parks, immigration reform, ecology, defense, whatever you want to spend money on. If you're spending a lot of money, too much money, and not getting good results, that's not good as a society for health policy. The other thing is, like, if you look in 2007, 60% of all personal bankruptcies were caused by a health problem. 60% of personal bankruptcies. So what number of personal bankruptcies in Japan are caused by healthcare? 0. What number of personal bankruptcies in the UK are caused by healthcare? 0. What number of personal bankruptcies are caused in France by healthcare? 0. And so this author who's thought about this a lot says, unless you're Warren Buffett, your family is just one serious illness away from bankruptcy. That's a societal problem that goes beyond just healthcare. So I think I've convinced you that we spend way too much money on healthcare and we don't really get the great things out of it. Why do we spend this much money on healthcare? A lot of it is small area variations. Anybody here from South Dakota? Anybody here from South Dakota? Anybody here from Florida? Somebody's just, yeah. Okay, anybody here from Miami? Okay, it's all your fault, you two. We got a problem. I mean, basically, Medicare, which is what pays for health care for people over 65, the average cost per person was $5,000 in Rapid City, South Dakota, and $14,000 a person in Miami. Wow, but in Miami, they must get better health care and have better outcomes, right? Wrong. They have worse outcomes. Wow. What's that about? It's probably about, in Rapid City, South Dakota, they have a lot more primary care. People don't just go to dermatologists and neurosurgeons and ophthalmologists and neuro-ophthalmologists without any coordination. And there's a lot of waste in the system in Miami. So that's a stunning kind of figure right there. We'll just do one more of these. The last 2 years of life, two really great places, UCLA and Mayo Clinic in Rochester, Minnesota. In the last 2 years of life, the average cost of someone who's treated at UCLA is $93,000. The average cost at Mayo is $53,000. They both tend to have excellent outcomes. If we could teach the UCLA doctors how to do this the way they do it in Rochester, Minnesota, we'd save about $700 billion a year. I gave this talk at UCLA and it was not well received. There's a different style of medicine at UCLA. They never give up. They never refer people to hospice. When you die, your electrolytes are in perfect balance and you have a lot of tubes in you. That may or may not be how you want to go. Both my parents died on Whidbey Island in Washington at home with hospice care and didn't go to the hospital at the end. Now that should be your choice. I don't think the government should tell you what you do, but you should have the choice and know that you have the choice. Okay? So that's a big deal. So there's a lot of waste in healthcare. We spend a lot of money on healthcare. And let's skip, let's skip that. So basically that's the federal budget deficit, that we, as a country, spend more money than we have. We have to keep borrowing money from people, notably the Chinese, and that's unsustainable. And so we have to either cut spending $4 trillion, which we really can't do because if we fired everybody, that would only cut it about half as much. And we have to either cut spending or raise taxes or a combination thereof. So that's a big deal. That's a big deal. And that's why I say in some ways, it really didn't matter, although it does matter, whether Romney or Obama won. Either one of them would have really, really tough time figuring out what to do with that spending cut or that raise in taxes. Well, the other big thing that's happened is the ACA, the Affordable Care Act, the Obamacare Act. So that's the second thing we want to talk about. And what's important to understand about this, although there's been so much controversy about it, it really is a very middle-of-the-road way to go about this. It wouldn't be the way I'd do it if I could start all over again and figure out the best way to design a system. What they decided to do was to retain Medicare, retain Medicaid, retain the VA, retain the CHIP system, retain the federal employees' health care system, and really just build on the private system that we have now. They didn't go to a one-payer government thing like the UK. They didn't even have a public option, which most liberals wanted, okay? And it basically is a plan that almost got through with Nixon and Ted Kennedy a long time ago. It's a Republican plan, basically. It came out of the Republicans and this is the way to build on what we already have. What they said was that you have to have employer-furnished insurance is retained, an individual mandate, and that's that everybody has to have insurance, and that's what got challenged in the Supreme Court. And most people thought that that challenge wouldn't go very far because most scholars, and we have one in the room, thought that the individual mandate was pretty well covered under the Commerce Clause. Looked like it was in fact, most constitutional people at law school said this is not going to go anywhere, this challenge. But the right wing said, no, this is really bad. And although the Supreme Court 5-4 upheld the individual mandate, they didn't do it on the Commerce Clause, which is kind of interesting. They did it on a tax clause. But unless you're going to law school, you probably don't care about that. So we'll just go over that. But the individual mandate, which just means that everybody, with a few exceptions, has to have insurance. Why do we do it that way? Why does everybody have to have insurance according to this theory? Why do we do it that way? Anybody? Why would you want everybody, if you were for this, to have insurance? What do you think?
I think maybe because it might be cheaper in the long run, because the insurance has to pay a portion of your healthcare bills. So.
Yeah, I mean, if you look at this room, we got 120 people here. I hate to tell you, but some percent of you is going to get really sick pretty soon. I don't know which ones of you are going to do it, but some of you are going to get sick, and most of us aren't. You have to have everybody insured. You have to have as big a pot as possible to pay for those folks that get sick by having people that don't get sick pay into the system. You see what I mean? That's the idea. The bigger the pot you have, the better. Now, the ACA has totally ruined the business model for healthcare insurers, and they're really upset. They're not happy, and they're reinventing themselves. Because basically, without putting too fine a point on it, healthcare insurers in the past made a ton of money by processing claims, but by trying to insure folks that would never get sick, and trying to avoid insuring people that would get sick. So they like young people. You guys look great. You guys over here, not so great. You look like you might get sick. Not you. You look okay. What are you sitting there for? So basically, the way insurance companies made a ton of money was, and you've heard about this, before the ACA, if you were a woman, you paid more for healthcare insurance. Absolutely. It was totally legal. That's what happened. Why? Because you guys have babies, and when you have babies, sometimes you get sick and you have problems. The ACA, you can't do that anymore. All I'm trying to say is that the ACA now says the business model of healthcare insurance is totally disrupted and gone. And they're frantic. They're even asking me for some help. They're really frantic. For what are they going to do? How are they going to make money? Most of them say they're going to make money becoming data miners. So that comes back to technology and changes. So we'll get to that in a second. Then there's subsidies for those that are too poor to pay, and insurance exchanges. So by 2014, every state has to either put together an insurance change or let the federal government put together an insurance change so people can buy their insurance on a new thing called an exchange. Okay? So basically the point is, it's a Republican plan, was pushed in building on the system we have today. And what's great about this is that it tended to get everybody very angry. The left wing was furious. Obama sold them down the river. Obama didn't put a public plan in. Why don't we just go to a single payer system and get it over with? The right wing was, you're like telling us that we have to buy insurance and you're putting somebody in between me and the patient and the doctor. So and they didn't do a very good job of selling all the good things, like when until you're 26, you can stay on your parents' insurance. My son just started NYU graduate school. He's back on our insurance. Now, luckily, he's not living with us, so that's good. But, so basically, it's a pretty middle-of-the-road thing that created a huge firestorm, a series of policies, regulations, subsidies, and mandates that builds upon the incoherent medical system we have, most important healthcare law since 1965, and then we had really uncertainty till the Supreme Court, and a huge surprise, when Chief Justice Roberts, who never sides with the liberals, just actually changed his mind and decided to side with the liberals because he just thought it would be too big a blow-up if they threw out something that looked pretty reasonable. I mean, that's basically, near as I can tell. He hasn't talked to me, but I've been reading books, okay? So that's what happened. Then they said, well, we still don't like the fact that we have this Obamacare, and Romney's going to get elected. And how many times did Romney say, the first day of office, I'm going to repeal Obamacare? He had he had 19 other things he was going to do on his first day of office. He was going to be kind of busy that day. Luckily, he doesn't have to do it now. He's not going to do that. But we have a November election. He lost. Get over it if you're right wing. So basically, the Obamacare is not going away. There's no way they can stop it. It's going forward. And now we have some certainty of what the rules and regulations are. When you go back to 1965, when Medicare and Medicaid were first put into place, the exact same thing happened. The Ohio delegation of the AMA, the doctors, I'm ashamed to say, said, we will never accept Medicare payments. This is communism. This is the end of the free world as we know it. And a fellow named Ronald Reagan went around, and GE paid for him to go around and say, this is the end of life as we know it. After the Ohio doctors decided, gee, this looks like we can get rich doing this, they suddenly didn't think it was socialism. And all doctors in Ohio, except not all, most except Medicare. My only point is that when you get these big, big changes, and this is a big change, people go crazy until it kind of settles down and works through what's going to happen. So we're going to say a bunch of stuff that's going to happen in 2014. States will have to expand Medicaid. But there's a curveball. The Supreme Court said, the way it was written was states have to expand Medicaid or else they lose the money they're getting now for Medicaid. And the Supreme Court said, states have to expand Medicaid, but they can choose not to expand it and still retain the monies they're getting now for Medicaid. So Medicaid is a insurance program mostly for poor people, also for older people who can't afford nursing homes. Now, what you have now is a really interesting thing where you have some governors like Rick Scott in Florida, Perry in Texas, who are saying, we will not expand Medicaid at all. And then the hospitals and doctors are saying, whoa, what are you doing to me? We agreed to a bunch of cuts thinking that more people, 30 million more people would get insurance, about 17 million of them on Medicaid, and now you're not going to do it? Because the federal government pays all of it till 2020 and then 95% of it after that. So, but Rick Scott, governor of Florida, and Rick Perry, the governor of Texas, are saying, no, it's bad. It's the government intruding. Now, if you think about it, that's a really tough thing for them to do. Because if I were going to run against Rick Scott in Florida, do you want to be my campaign manager? You're from Miami? Okay, we'll talk about it. I would say, gee, Governor Scott, that's interesting. Because of your your difficult, stubborn stand, Florida tax dollars are going to pay for people in Pennsylvania for their health care. Does that make any sense, Floridians? I mean, that's a tough one. So, and same thing in Texas. So I think that even though they've been saying that, now that Obama's won, some of them are going to say, maybe we'll do it. But eventually they'll have to do it, near as I can tell. So that's happening. Insurance subsidies for the uninsured and workers in small businesses. Insurers can no longer deny coverage or charge more for pre-existing conditions, like being a woman or being young with asthma. You didn't realize that being a woman was a precondition. I'm sorry, it is. It used to be. Not anymore. So that's what's happening. Now, there's some cost containment in the ACA law, but not much. And there are things that I call faith-based cost control. Because we said we got to cut this $4 trillion out, right? And Medicare and Medicare and healthcare is one of the biggest contributors to that huge amount of money. But what we're saying is comparative effectiveness studies. Let's do studies and figure out what works and only pay for what works. Let's have voluntary savings through ACOs. Now you're going to hear accountable care organizations, which basically they're going to say is that fee for service, where every time I see you I can charge you, they're going to change the way we pay doctors and hospitals and say, here's a lump sum of money, keep this population healthy. Here's a lump sum of money, do whatever you want with it. You want to surgerize everybody? Fine. You want to give CAT scans to everybody? Fine. But that's all the money you're going to get. And that changes the whole game. Because suddenly if I see you more often, I don't get any more money as a doctor. Suddenly if I put you in the hospital, I don't get any money as a hospital. So the problem is under fee-for-service, where we are now, hospitals want to be filled up to the brim. Under this new way of paying for stuff, hospitals want to be empty. That changes the entire culture. It makes primary care and prevention more important, makes surgery and neurosurgery and orthopedics less important. And yet right now, the most important doctors in the hospital in private practice are the orthopedic surgeons and neurologists because they make a lot of money under fee-for-service. If you change that, they don't. But they still are powerful because they have big houses. I mean, there's a cultural change there that's going to really cause some problems. And I spend a lot of time running around the country talking to systems about how do you make money in a new way of getting paid. Bundled payments, reimbursing physicians based on quality. So this is just shocking, and most doctors don't know this is happening. But right now in the Midwest, they have this physician quality and research use reports. They're going to develop a value-based payment modifier, and they're basically going to allow every doctor in Iowa, Kansas, Missouri, and Nebraska to see how they do, both on quality and on cost, taking care of patients. So why is that so upsetting? Well, that's upsetting because doctors don't like to be told that what they're doing might not be right, and they certainly don't want to be told you're taking care of patients and you're spending more money than your colleagues. So basically, but then in 2017, again, since Romney got defeated, and this is going forward, in 2017, this approach will happen to everybody in the country, being piloted in the Midwest, so that every doctor will start getting reports. And the reports will look like this. Well, let's see, let's go back one. The reports are things like COPD, which is lung disease, bone disease, cancer, HIV, prevention, diabetes, GYN, heart conditions, mental health, and medication management. So that's what they're going to see if they can take a look at and figure out what's up. So this is an actual graph. I used to be the chief medical officer in Iowa, so my friends that are doctors in Iowa are just beside themselves. They're now getting stuff on an individual doctor basis like this. This is the distribution of cost per care of patients whose care was directed by you, and this is where you came out, $13,000 for this diagnosis. You weren't the worst, because some folks, well, these two guys way up in the corner, they're real expensive. But look, here's some other guys doing the same thing, and gals, for $10,000. And also they're going to have feedback on quality. So for the first time, there's accountability in this system. We don't have that much accountability in the system right now, but the federal government pays for more than half of all of health care, and they're saying, we're paying for it. Why shouldn't we be able to check up on you and say whether you're doing it right? Doctors think that's very unreasonable. Why? Because they've never had it before. Right? So, how many people in here have read the entire ACA Healthcare Act, which is 2,725 pages? Anybody read it? I've read it. I've read it 4 times. Which says what? It says, I have no life, and you all should not strive to be like me. But it also says, I actually know what's in there. And I can summarize all 2,700 pages in 4 words. This will be on the test. Write it down. No outcome. Grace, why are you yawning? I'm scintillating. Stop. Grace, you come in late, you yawn. What are we going to do with you? Okay, so the entire health care bill. No outcome, no income. That's what they're saying here. We're going to track whether what you do is high quality and whether you cost a lot of money as a doctor. And if you do it, if you're down here and if your quality is really good, we're going to give you some more money. If you're up here, we're going to give you less money. In any business, that would make sense. In healthcare, that's catastrophic and revolutionary and transformative and a big deal. No outcome, no income. We're going to measure you. Why everybody has to be on electronic medical health record is we can measure this kind of stuff and feed it back to you, right? So that's a big deal with what's going on with the ACA. Questions that matter? The uninsured have to get insurance. If they don't buy insurance, it's a very small penalty. Will employers stop giving insurance? We don't know, probably not. Will delivery systems changes reduce cost? Will states comply with the mandates? Does the public understand the ACA? No. Will the states expand Medicaid? So this is going to be bumpy and lumpy and a big problem, but because Obama got reelected, it's going to happen. It's going. It's for sure happening. So that's a big deal with the ACA. These are different ways that we pay for stuff. I don't want to get into a lot of this, but this is healthcare as I see it. Over here is you're healthy and doing well, continued health. Over here is you're hospitalized. Basically, all this says is, if you're a healthy consumer, you just want to stay healthy and never go in the hospital, right? Let me ask, do you guys like going to the hospital? You're old. Have you been in the hospital? Do you like going to the hospital? Of course not. Bad things happen in hospitals. You get MRSA infections. You get the wrong pills given to you. Bad things, seriously, bad things happen in hospitals. We want to stay healthy. I want to stay healthy, and about 100, when I'm 100, just die someday after the Eagles finally win the Super Bowl. Could take a long time. Could take a long time. So continued health, no hospitalization. This is hospitalization. Our entire system is based on hospitals, on specialists, on pathologists, on radiologists, on surgeons doing stuff. Okay? If you think about it, under fee-for-service, where every time you do an x-ray you get money, you're incentivized to do as much as you can, right? If you now go to a global payment, which they're going to, a capitated payment, if you will, suddenly you get the money up front to take care of this entire room. No matter what happens, you can do it anyway. You're better off preventing people from going to the hospital, right? So suddenly primary care and prevention become really important to the financial health of the system of the ACO, the Accountable Care Organization. And what you want to do is everything you can to keep people out of the hospital. Now, what are those red X's for? Those are things that we do now under fee-for-service, and the system makes more money if we do more of them. Preventable condition, acute care episode in the ER, high-cost successful outcome at Penn, complications, readmissions. Basically, by changing the way we pay doctors and hospitals, we can say those are no longer things we're paying for. They're gone. And the big thing is, whether it's Jefferson's Lankadown Hospital, whether it's HUP, whether it's any hospital, right now under fee-for-service, they want to be filled to the brim doing stuff. Under the new system, they want to be empty because they've got all the money up front, and every time they do a surgery, it's money out of the doctor's and hospital's pocket. That's the big change, and that's huge. And the vehicle that that's going to happen with is supposedly this accountable care organization, which are brand new and which are under the law, and people are really, really trying to figure out how to make that work. All right. So basically, we've now covered the federal budget deficit and the Affordable Care Act, and those are the more boring things that we have to talk about. And now we can get to, I think, some more interesting things. Questions, comments about that? Does that make sense? Are you with me? We spend too much money on healthcare. We're 37th in the world. It's unsustainable. It's tied into the federal budget deficit. Big deal. Questions? Somebody's got it. Yeah, I asked a question. I'm not going to pick on Grace anymore. Yes?
Do the hospitals that get the lump sum of money get to retain the money that they don't spend? Or what
Yes.
happens to their-
Exactly. So you're taking care of all these people, and right now, if you have diabetics are out of control, sometimes have to have their toes amputated. Okay? Right now, we make money doing those amputations at Lankenau or up. If we get the money and prevent the amputations from happening by doing really good, getting them to eat and getting them to walk and getting them to have their hemoglobin A1Cs correct, we get to keep the money. That's exactly right. So wellness, that's why wellness is now a big deal. When I went to medical school, wellness, forget about it. Now, big deal, because we're changing the way we pay. Yeah?
How does that work with private practices when they're not yet diagnosed?
Private practice is going away. Right now, and the reason it's going away is the regulations, the difficulty in spending all the money for the computer systems you need, and the fact that doctors are just now saying it's not worth it. So about 4 years ago, only 30% of doctors were employed by hospital systems. I just checked, it's 75%. So basically doctors, and I actually do a lot of this around the country, they're fleeing private practice like crazy. And the other reason is you guys, you're millennials, you Gen Yers, you Gen X. Any Gen Xers in here? You're Gen Yers, you're millennials. And you want work-life balance. You don't want to go into private practice. I'm serious. You don't want to go into private practice and stake all your thing, be your own boss in a small thing. You want, let me go work from 9 to 5. I don't want to take a night call. It's a big change. But private practice is going away. There may be small pockets of it. But that's one of the big things about all these changes are private practice is going away. And it's going away because people are scared of if you think about it, you have five of us, these three, and you and me, we're a 5-person. What do you want to be? You want to be OBGYN or family practice? What do you want to be? OBGYN. They got to vote. Okay. So we're OBGYN practice, 5 of us. We're the best. We've got to now buy a huge computer system that costs hundreds of thousands of dollars, if not millions. And that comes out of our salary, the 5 of us. If you join Jefferson or Penn, they pay for it. That's one of the big things. And then the regulations. All these new regulations are very, very difficult for private practice docs to digest and comply with. So private practice, unfortunately or fortunately, is going away. I don't know if that's good or bad, but it's happening. Yeah?
You're saying like you would get a certain amount of money and then like whatever you don't spend,
Yeah.
you would save. But then would you get the same amount every year, or like would they get more because then like, doctors would never get an increase and potentially get a cut?
It's all negotiation then. I mean, basically. But, if you're a salaried physician, my wife is a salaried physician professor at Penn. She's an OBGYN professor. She doesn't make big salary increases every year, but she doesn't have to worry about malpractice. She doesn't have to worry about running her practice. She can just see patients. She likes that. So what are you going to do? Yes, sir.
What about people that are still covered by private insurance? Because shouldn't the ACOs only cover people that are...
No. Actually, there's more ACOs being done by private insurers now than by CMS. Private insurance always follows CMS. Medicare is more than half of all the payments in America. And all the private insurers now, I was just talking to them yesterday in DC, they're saying, because they don't like the overuse by doctors. So they're saying, hey, we're now going to change the way we pay you. Independence Blue Cross is doing this right here in River City. They're saying, hey, we kind of like that. We'll give you a lump sum of money. Do your thing. Because insurers and doctors hate each other. I mean, they've always hated each other. Because the insurers are saying, you guys do too much to make your own money. And the doctors are saying, you tell us what to do, and it's cookbook medicine. But the private insurers are scared to death of all these changes in healthcare. They can no longer discriminate against women, no longer discriminate against people with pre-existing conditions. There are no longer yearly caps. There are no longer lifetime caps. Their whole business model is disrupted, and they're scared to death, which is why Highmark in Pittsburgh is trying to buy up a failing delivery system. They're saying, oh, now we got to be like Kaiser. We have to have both the hospital and the doctors. I mean, whoa, and that's crazy. They're losing $100 million. It's wonderful for people like me, but it's crazy. It doesn't work. There was another question way in the back.
75% are now employed under the hospitals.
Yes.
What is the change in the methodology, like the methods of the hospitals now wanting to get patients out of the hospitals?
So basically, they're saying we want to build up our primary care network, and we want all this care to happen outside the hospital, and we don't want you to have a lot of people in the hospital. And the hospitals are having a really hard time adjusting to that, because those guys who got their MHAs and they're used to building buildings, and they're used to a culture where they've always been successful by having high hospital attendance rates. So that's, I'm trying, these are good questions. I'm trying to say there's a big cultural change that is very difficult for all of us to get our arms around. Maybe we could do some primary care with algorithms and advanced nurse practitioners. Advanced nurse practitioners are cheaper than doctors in general. Bet your doctors love that, huh? I mean, but it makes sense if you look at how we're doing stuff. Or PAs, or sociable humanoid robots. We could replace doctors and nurse practitioners with IBM's Watson. I'm serious. IBM Watson is now working with Columbia, Memorial Sloan Kettering, Cleveland Clinic, because much of primary care is algorithmic. When you go to CVS, I mean, you get your strep throat is your strep throat. They give you ampicillin. It's not like that, not that tough, right? So Walmart is now getting into primary care in a big way. Big changes. And we haven't all gotten our arms around what they mean. Big deal. Let's quickly talk a little bit about two more things. Demographics, pretty easy. By 2011, more than 8,000 people a day turned 65 years old. The senior population is now about 12 million. By 2025, be 72 million. And you'll be paying for my Social Security. Thank you very much. Get a job. I'm not laughing. You shouldn't be laughing either. The population 85 and over, in 26, it was 5 million. 2050, it's going to be 21 million. People are living much longer. My lovely mother-in-law is here to hear me, and she lives with us, and she's almost 90 years old. What a saint am I? Think about it. My mother-in-law lives with me. Why are you guys, you're supposed to laugh at that? Laugh. Thank you. So we're getting older. Seniors want to stay in their own home. Let me ask, Margie, do you want to go to a nursing home? No. AARP, 89% of people want to age at home. That's a big change. That's a big deal. So the demographics are huge. And let's wrap up with technology, because you guys are the digital natives. I'm a digital immigrant. But one of the biggest things I want to wrap up with is technology is going to change everything. And so here's a guy, David Agus, who actually was one of the doctors that consulted with the guy Apple, Steve Jobs, when he died. Take a moment to imagine what it would be like to live robustly to a ripe old age of 100. Then, as if your master switch clicks off, your body goes kaput. You die peacefully in your sleep after your last dance. You don't die of any particular illness. You haven't gradually been wasting away under the spell of some awful disease that began years or decades ago. The idea now that we've got a convergence of a bunch of stuff that is going to totally change medicine is another thing that we haven't really got our arms around. The human genome. We all carry around computers that are more powerful in our pockets than people had 10 years ago, a huge mainframe computer. We can remotely, continuously monitor vital signs, mood, and activity. There's little tattoos you can put on. There's Nike shoes with Fitbit to make sure you do your 10,000 steps a day. You can image any part of your body. You can put your entire medical record on your smartphone. What does that mean to digitalize a human being? We know what it means to digitize a book. It means that Amazon makes money and publishers go bankrupt, and they're all consolidating, just like doctors, just like health plans. We know that now authors can self-publish. So digitizing books has changed everything about writing stuff, right? What does it mean to digitize a human being and stick it on here? We don't know yet, but it's going to change everything. And let me just give you a couple examples where genomics, wireless sensors, imaging, information systems, social networks. How many people here are on Twitter or Facebook? Okay? Think about, this is not partisan at all. But the reason Obama won the election was that he was actually taking the social networks to a way, way bigger area than the Republicans. Osceola County in Florida shocked Romney. They didn't think that was anything. Obama identified a bunch of new voters and got them to the polls, and did it by micro-targeting, so that the emails you get are actually because they know who you are, okay? Social networks, Facebook. Facebook brought down the Egyptian president. I mean, this is huge in the sense that Romney really thought he was going to win. But what happened was the Obama team had built on the ground thing. And actually, I've witnessed part of it. The Bryn Mawr college students got totally mobilized for Obama and were going door to door making sure that their people voted. It's a huge, my point is, if you're always using the old technology, someone else will do it better and will beat you, even though the old way of doing things, targeting white Southern male voters, was great for Nixon, was great for George Herbert Walker Bush. It's no longer working because the census says that we're more diverse. And technology allowed Obama to do that. Whether that's good or bad is up to you to figure out. So what I'm saying here is, let me just talk about this one thing. So Agus actually treated Steve Jobs, who had a pancreatic cancer, the head of Apple. Jobs had both his cancer and his normal cells sequenced so he could get targeted chemotherapy based on the genetic problem of his tumor. They kept changing what they were giving him because the tumor kept changing. So this is like cutting edge stuff that's actually starting to work. And Jobs said, I'm either going to be one of the first to be able to outrun a cancer like this, or I'm going to be one of the last to die from it, either among the first to make it to shore or the last to get dumped. So basically we have this technological revolution that's happening. And let me just give you a quick, this is stuff I really like, but show how much the paradigm is shifting. I used to be a pathologist, so I looked in the microscope and diagnosed cancer. Adenocarcinomas of the lung were adenocarcinomas of the lung. That's how we diagnosed them, that's how we classified them. They all look the same. We now know that even though they look the same, some have a driver mutation for this gene, and we have a drug that we can treat it with. It's oral, and it works. These adenocarcinomas that look exactly like those adenocarcinomas have a different gene that's turned on, and they have a different drug that counteracts that biochemical mechanism. Now, what's even more exciting is there just came out in Nature a study of breast cancer. So in the way I grew up, I'm 60 years old as a pathologist, was there breast cancers, there's lung cancers, there's colon cancers. The cancer is classified and treated by where it started. You with me? Now, they've looked at breast cancers and discovered, oh, there's 4 types based on what gene is turned on. And in one type, it's the same gene that's turned on in some ovarian cancers and in some lung cancers. So gee, maybe we should treat those cancers not as ovarian cancers or lung cancers or breast cancers, but as cancers of that gene that's turned on. It totally turns upside down my world of pathology, of how you classify tumors, how you treat tumors, how you develop drugs for tumors. Are you with me? This is a big deal in terms of now we have some people that were never treatable with melanoma or lung cancer that we can treat by turning off the gene that's turned on. And just to give you, last thing, to give you just a sense of this, this guy, Lucas Wortman, is at WashU, which is a research university in St. Louis. And he developed adult acute lymphoblastic leukemia, usually a fatal disease. What they decided to do, he was actually studying these kind of things. He then said they sequenced his cancer cells and his healthy cells. And they discovered by doing all of that sequencing, there was a normal gene that he had that was in overdrive producing huge amounts of proteins. You know, genes are DNA and they RNA, and then you get the proteins and that. So they have a gene that no one ever thought had anything to do with leukemia, pumping out proteins. It just so happened we had a drug for a different cancer that would actually attack that one malfunctioning gene. They gave him that drug, he's in remission. Wow. He just developed this terrible kind of cancer. We now can discover by comparing his normal genes with his tumor genes what's turned on, and we happen to have a drug that turns it off. Now, we don't know if he's in remission forever. We don't know if he's going to get terrible side effects from that drug. We don't know a lot, but he's pretty happy. He's not dead, and he would have been dead if they hadn't done that. Now, would his insurance company pay for that? No. Just to say the health policy issues that come up, It's terribly expensive. When Steve Jobs did it, it cost over $100,000 to do his cancer genome. But he had a lot of money, so he was able to do that. So I'm just saying that the technology that we have, and this is just scratching the surface, is also going to tremendously change the way that we do medicine in the future. So the main message I wanted to say was the 4 things I think are really affecting medicine today. Federal budget deficit, and I'm assuming we're going to get that under control, maybe. But that's going to mean less money for hospitals and less money for doctors, no doubt about it. So we're going to have less money, so we have to decrease per capita cost of our care, increase the quality. So that's 1. 2, the Affordable Care Act, which we're now just kind of figuring out how it works, but we're going to have 30 million more people with insurance, which is good, I think. We're going to have people be able to get subsidies to buy insurance on an exchange, and the insurance companies have to figure out how to make money in a new business model. Demographics, we're getting older, and that's a big problem. And then technology, we don't know what does it mean to digitize a human being and put everything on a smartphone. I think it means hospitals become less important. I think it means much more health care is delivered in the community wherever you are with your smartphone. I think it means nurses have a much bigger role. I think it means computers have a much bigger role. I think that this kind of thing that we showed you from Iowa, where they're going to be giving you much more feedback on whether you cost too much as a doctor or whether your quality is up to snuff. So there's a lot of changes happening, but the take-home message is, what a better way, what a better time. There is no better time to be in medicine. It's really, really disruptive to old people that don't like change. But to people like you that are used to like never talking on the phone and always texting, right? I mean, I can't believe how you guys don't really talk face to face. Everything you do is texting. That's because you're a digital native, and I'm not. You're much more equipped to be able to take these technological changes, understand what's happening with the ACA, and deal with the demographics. And you have to, because somebody has to take care of us as we get older. And so all I'm saying is that it's really upsetting to more older doctors. And I spend a lot of my time trying to convince them that these changes are not necessarily evil. But it doesn't have to be bad, but it has to be that you have to co-create a new system that isn't comfortable with fee-for-service, recognizes that does get rid of the problem of overuse, and that by using technology, you could really change the way that we deal with people and have it much more community-based, wellness-based, as opposed to sickness-based. I grew up in a system where health was defined as absence of disease. You all know that it's much more than that, right? It's whether you're happy, it's whether you're spiritually connected, it's whether you feel like you're growing, right? I mean, health is a lot more things than just absence of disease. And so with all of this stuff, you can actually then create a system that is much more patient-centered and much more what people want. So that's just kind of an overview. We didn't get through everything. If you want the rest of the slides, send me an email. I'll be happy to send them to you. I think we're right on target, and we probably have time for a couple questions before we break to go down and have lunch. And I guess there's a panel after lunch, which you may want to stay for. Questions or comments about that? I hope I didn't turn you off from a career in medicine, because that's not what I'm trying to do is tell you that things are really changing rapidly, and that can be very exciting. That can be a good thing. Yes?
And when you're talking about like older doctors who have to get with this new technology, how does that affect that?
Most doctors right now who are my age are very depressed and angry and voted Republican. It's true. I mean, I deal with them every day. And many doctors that I met in DC yesterday were saying, gosh, we really thought Romney was going to win. It would all go back to normal. But it's not, because of the federal budget deficit. But that's okay. I mean, it's not about us, it's about you. I mean, you guys are the future, not us. But most older physicians, many older physicians are very disgruntled. And you can't really blame them in the sense that the system has changed so much, but it's totally unsustainable. I mean, what we have now is unsustainable. So, what are you going to do? Yes?
What does this mean about physicians as opposed to PAs and NPs and primary care? Can we actually encourage more younger people going into medical school to go along the primary care path, which is now difficult to convince? Or are we actually going to turn all of that over to physician assistants?
Probably both. We have most physicians right now look out and see that you can make more money as a cardiologist or as an orthopedic surgeon. When that starts changing, you may get people that are more interested in it. I think we're really going to change the way that Watson and those computers are going to help all of us do a much better job of primary care. Primary care is hard. So I'm not sure the answer. I mean, a lot of people narrowly focus and say, we just got to get more medical students to go into primary care. I'm not sure that's the answer. I mean, I think it's going to be a combination of more nurse practitioners. I mean, basically, it's whoever can deliver the best care the cheapest is going to win. And that's probably going to be a computer with an algorithm eventually. I'm serious. I mean, but a nurse or a PA, my wife is an OBGYN professor at Penn, sees patients every day, some at Radnor, some at Hupp, and you actually talk to her and you say, Annie, what % of what you do you really have to do as this incredibly smart professor at Penn? She said, about 30, 40% of the people I see. So 60, 70% could be seen by a nurse? Oh, absolutely. No problem. But the way the money is exchanged now, Penn still has her seeing those people. As soon as the money exchanges change, that'll change. So again, I don't think that we know exactly how it's going to play out, but I do think that there's going to be much more of a issue about primary care maybe supervising PAs and supervising Watson and be less the one-on-one that we have today. I mean, everything's changing. I guess that's the big thing. Patients have to change, doctors have to change, hospitals have to change, insurance companies have to change, and most people don't like to change. They get in ruts. And I think that's the biggest problem. Well, thank you for your attention. Enjoy your lunch.